Good afternoon, everybody. This is Congressman Mike Levin. Thank you again for joining us for another virtual town hall on COVID-19. Whether you're joining us on Facebook or Twitter or YouTube or on our website, we're glad that you're here. And I hope that this is an informative 90 minutes or so, where we're going to hear from another leading public health expert and also hear a lot about the policy changes and the things that we've tried to do in Washington to address both the public health crisis and the economic crisis that we face during this time. Joining us this week is a fantastic guest. Dr. Cheryl Anderson is here to help answer your questions and provide updates. Dr. Anderson is a professor and interim chair of the Department of Family Medicine and Public Health in the School of Medicine at the University of California, San Diego. Dr. Anderson's research focuses on nutrition and chronic disease prevention using observational epidemiological study, randomized clinical trials, and implementation science. Dr. Anderson is a director of the UC San Diego Center of Excellence in Health Behavior and Equity. She was a member of the 2015 U.S. Dietary Guidelines Advisory Committee and served on the National Academy of Medicine's Food and Nutrition Board. She's the current chair of the American Heart Association's Nutrition Committee and was elected to the National Academy of Medicine in 2016. She's also a leader in developing testing and contact tracing capabilities for UC San Diego and, for that matter, all of San Diego County. And I know she's going to say a little bit more about that in just a moment. But Dr. Anderson, what an honor to have you join us today.
Well, thank you. When you say that, it reminds me that I should thank my parents and my partner and my mentors for helping me to get to that kind of resume. I really appreciate this opportunity, Congressman, and what a great way for us to dialogue as a community around what's going on around us right now.
Well, we are grateful that you're here. And my goodness, chair of the American Heart Association's Nutrition Committee, I need to see if you can get my 7-year-old and 6-year-old to diversify and eat more green vegetables and less peanut butter and jelly sandwiches. But we'll have that discussion. We'll have that discussion later.
Yeah.
Obviously, it's been a very difficult time for our country and really for the world. And the United States, sadly, this week passed 92,000 deaths, with about 3,000 of those deaths, a little over that, happening here in California. But these are so much more than just statistics. And I've said this before and we'll say it again. These are husbands and wives, sons and daughters, brothers and sisters, loved ones, relatives, friends, coworkers, colleagues. And I'm just incredibly heartbroken when I hear the stories of those in our local community who have been impacted by this. And I just hope everybody is staying healthy and safe during this tragic time. We now, unfortunately, have crossed 1.5 million cases of COVID-19 in the United States, 1,539,633 to be exact, 92,645 deaths, as I mentioned now, approaching 100,000. California has confirmed a total of 83,864 cases, as I said, 3,420 deaths. San Diego County now has confirmed 6,026 cases with 222 deaths. Orange County has confirmed 4,500 cases and 88 deaths. The stay-at-home orders continue. I understand everyone's frustration. I do, however, see signs of optimism as we have done quite a bit in California to flatten the curve. We have seen now the governor begin to discuss the relaxation of some of the standards, particularly for those counties that have met certain criteria with regard to rate of infection and death, testing and tracing. So I do look forward to the day where we can get past the most difficult of these restrictions, when our businesses and our residents can go back to a new, as close to normal as we can get. But I would just encourage everybody to whatever extent and how, as difficult as it is, we've got to stay the course. We've come too far to only get this far and not to see these practices through to make sure that we're doing everything we can to reopen safely and responsibly in the weeks and months ahead. I wanted to talk a lot today about testing because Dr. Anderson truly is a expert on testing and contact tracing. In terms of how much testing is needed, the numbers being used by both the state of California and the county of San Diego rely on modeling that suggests we should be administering a minimum of 152 tests per 100,000 people per day. So in a county like San Diego County, that's an objective of a little over 5,000 tests per day. I've been encouraged to see this past week, San Diego County has been anywhere from 3,000, 3,500, 4,000, all the way up, I think, close to 4,500 tests one day. And I'm very encouraged by that. My district also includes Orange County. The numbers in Orange County in terms of testing have not been as high. I have a meeting tomorrow morning where I'm going to be asking the public health officials in Orange County to discuss the discrepancies between Orange, San Diego, Riverside counties, and also a path forward on contact tracing so that we can do all we can to work collaboratively to hopefully try to provide whatever federal resources we can to help meet the objectives as set by the state. I did lead the Orange County congressional delegation last week in requiring or in asking for an outline of the requirements around testing. I think one of the questions that I have, and we'll get into this with Dr. Anderson, is exactly who we're testing and why we're testing them. As I mentioned in our past town halls, we've now passed 5 major bills in the House to deal with this coronavirus crisis. The first was back at the beginning of March, an $8 billion bill to deal with the vaccine. We're now seeing some progress in very, very early clinical trials on one vaccine in particular. But of course, we have a long way to go before we have a vaccine that works and before we're able to distribute it. And we have to make sure that we continue to empower a number of different companies who are developing those vaccines so that we can get something for the American people as quickly as we can. The second bill, the middle of March, was called the Families First Act. That was really focused on emergency sick leave and on support for nutrition assistance, so critically important right now. And we're not done with that by any stretch of the imagination. We need to do far more to make sure that people are not going hungry during this difficult time. And I commend the great work being done by all of our food banks. Christy and I, Friday before last, were at the Vista Distribution Center for the San Diego Food Bank, and they're doing an amazing job. And if you are in a position to help, I certainly hope that you will consider doing that. Then in the end of March, we passed something called the CARES Act, which you may have heard about. $2 trillion plus in federal assistance, everything from money for our hospitals to money for testing to money for PPE. Importantly, $150 billion for state and local government, which was a good first step, but not enough to really get the job done. And then, obviously it contained some major provisions for small businesses with the Paycheck Protection Program administered through the SBA. Then direct cash payments, the $1,200, which hopefully many of you have received by now. And then lastly, the expanded unemployment insurance, which includes unemployment for 1099 independent contractors as well as for gig economy workers. All those benefits are now available through the state employment development department as well. If anybody needs any help with any of that, with any of those benefits that are being provided, please contact our district offices. We'd be honored to help you. We've got offices both in Orange County and in San Diego County. Further, from the CARES Act, we passed an interim piece of legislation, $484 billion, to add more money to the Paycheck Protection Program, to set aside $60 billion for the community-based lenders, many of whom were not able to participate in the first tranche of PPP funds. We also added another $25 billion for testing, a requirement that the administration have a national testing strategy for both standard diagnostic tests and antibody tests by May 24th. So that date is fast approaching, and we still haven't seen that comprehensive national testing plan. We followed up on that bill most recently with the HEROES Act. This was another wide-ranging, comprehensive proposal, and I am very hopeful that Mitch McConnell and Senate Republicans and Democrats alike will work together. I don't expect for the Senate to agree with every word in the HEROES Act. It was a 1,815-page bill. I've got the summary of the bill. This is only the summary of the bill, and this is a very comprehensive piece of legislation, but so critically important in there is the $875 billion for states, cities, territories, and tribal governments, including a lot of places that were left out of the CARES Act. Specifically, cities smaller than 500,000 people were left out of direct assistance under the CARES Act, and that includes all of the cities in the 49th district. So I was very pleased and very happy to see all of our mayors in the 49th district come together on a letter that we sent to leadership requesting that smaller cities would be included in the HEROES Act for direct funding. And that's exactly what happened. We passed last Friday the HEROES Act. Again, $3 trillion, of which almost $1 trillion for states, counties, and cities. And of that, $300 million would go under that bill to the cities of the 49th district, including over $90 million for the city of Oceanside, over $70 million for the city of Vista, and every city in the district is set to receive funds under the HEROES Act. So now it's sitting on Mitch McConnell's desk, and we have to compel him to take action. You might remember Mitch McConnell said we should just let the states go bankrupt. Then he said we need to take a pause. But the pandemic is not taking a pause. The need for vast assistance from our local government, from our frontliners, our police officers, our firefighters, our nurses, our teachers, our medical professionals, that isn't taking a pause. So Congress shouldn't either. And we have to make sure that Congress moves forward with that legislation. We also, last week, we created the Select Committee on the Coronavirus Crisis led by Jim Clyburn, who is the House Majority Whip from the state of South Carolina, very experienced legislator, and their committee has already started aggressively trying to weed out waste, fraud, and abuse with how the existing funding for coronavirus is being spent, demanding that certain recipients of paycheck protection loans return those funds, and trying to get to the bottom of other issues pertaining to COVID-19. So a lot of good things are happening. We continue to move forward to try to save the United States Postal Service, to try to help low-income renters, to try to keep homeowners in their homes, renters in their apartments, to try to get hazard pay for our frontline workers, and to do much more than that. So we're going to just keep at it, and hopefully we'll be able to come together in a bipartisan way, just as we have 4 other times during this crisis. One thing that I try to do during all of these town halls is share the number for the National Domestic Violence Hotline. I've been saddened to hear stories of increased domestic violence during COVID-19, and I encourage anyone in need of help to call or text this number, 1-800-799-SAFE. That's the National Domestic Violence Hotline. Again, 1-800-799-SAFE. I'd also encourage everyone to please read the Coronavirus Federal Resource Guide that I published a couple of weeks ago. I thank my great staff in Washington and in our district offices for compiling that and for all their help, obviously, during this crisis. To find that, you go to mikelevin.house.gov/COVID-19. And that has a lot of information about all of the federal legislation and the different programs that are available to constituents of our district and small businesses as well. And before I turn over to Dr. Anderson, I want to give everybody a heads up that usually we would do a town hall next Wednesday afternoon. What we're going to do instead is a joint town hall next Wednesday night. And I'm very excited about this. Fox 5 San Diego and several other related affiliates across California are going to be airing jointly at 7 o'clock Pacific time next Wednesday, me and a number of my congressional colleagues in a town hall where we'll be taking questions live, and I think it'll be a wonderful and interactive discussion. So please keep an eye out for that next week, 7 o'clock p.m. For those in San Diego, they can watch on Fox 5 next Wednesday at 7. With that, I'm very grateful for Dr. Anderson again for being here. And if you have some opening remarks, and then I'll have a few questions for you, Dr. Anderson, and then we'll turn it over. We've got a ton of questions from our audience this week. So, Dr. Anderson, thanks again, and take it away.
Oh, you're welcome. Thank you for having me. So, as you mentioned earlier in introducing me, a part of my activities is professorial. And at the university, I have the great pleasure of every fall or so convening a class that is um, really full. Hundreds of students come in to learn about public health. And on the first day of class, I usually say to them, when things are going well, no one notices public health. And so it really tends to attract better angels. It attracts people who are compassionate, who feel comfortable working behind the scenes and without much notice. However, as we have been, in response to the pandemic SARS-CoV-2 infection and resultant COVID-19 disease, public health right now is a household word, right? We have all become familiar with the basic tenets of public health, which essentially allows us to remove the focus from the individual, which is what we usually do in medical care, and take our focus onto our community. And we think about how it is that we can assure the attainment of the highest level of health possible for all individuals equitably across societies. And so this response to the pandemic SARS-CoV-2 infection has really shown us some of the real strengths of public health in our nation and across our world. And it's also shown us where we've had some gaps in supporting public health infrastructure, gaps in how we prepare for emergencies that are public health in nature, and gaps around how we think about and communicate important public health principles to our communities. So I'm so happy to have this opportunity today to have this town hall with all of you so that we can get some of your public health related questions answered. Another thing that's incredibly important right now is that we have engaged epidemic modelers throughout the course of this pandemic to really help us figure out how to prepare and plan. Initially, our thoughts were, how do we plan for something that we've never seen before, right? The 2019 novel coronavirus. And how do we ensure that the impacts of the 2019 novel coronavirus would be bearable? How could we ensure that it would be bearable across our healthcare system? How could we ensure that we'd have enough ICU beds, that we'd have enough ventilators, that the systems that we're used to seeing run so efficiently would bear the burden of this infection and disease? And these models told us something really important about a public health crisis that public health professionals would have been thinking about, but others might not have. And that is, there's no getting out of a public health crisis without the implementation of strong public health measures. So what does that mean? That means that when you heard our San Diego Department of Public Health give us guidance on removing ourselves from congregate opportunities, meaning no gatherings bigger than the size of 10, that was a public health measure. And the goal of that measure was to allow us to distance quite a bit from each other so that we would prevent infection of a very highly contagious SARS-CoV-2. We shortly thereafter saw travel bans go into place, and in California here we saw a shelter-in-place order by Governor Newsom's office. Again, a very strong public health measure, allowing us to, in short terms, just remove ourselves from circulating with each other in the event infections were present in our environments so that we would interrupt transmission of the infection. Now, those epidemic models have been updated as we've learned more about SARS-CoV-2. And I sit here today in conversation with you, wildly aware of the fact that there is so much we don't know. We're learning daily, weekly, more about the biology of SARS-CoV-2 and its potential impact on our health and well-being. By using the word health, my intention is to include not just our physical health, but also there are neuropsychological and psychiatric sequelae of COVID-19 infection that must be a part of this conversation also. So recently, our epidemic modelers went back to look at how well were we doing according to what the models said, because we had enough time and we had enough experiences, whether those experiences were from China or from what we saw in Europe, Italy and France, or from right here in the United States in New York. And we saw that our most optimistic models were not providing as much accuracy in predicting around hospitalizations and deaths than we would have liked. So we went back, we pulled back a bit from, you may be familiar with the IHME model because of its use at the White House briefings every day, pulled back a little from that, particularly as it applies to San Diego, and began to look more at the Imperial College model to help us with our planning for the future. So what the Imperial College model told us was that when we here in San Diego County were doing public health measures, we were adhering to the things that I outlined earlier, we brought the infectivity of SARS-CoV-2, it's a term in epidemiological context that's called R0. We brought the infectivity from about 4. So from every one person having 4 infected down to below 1. Now, it was not at a half or at a 0. It was still at 0.85 or so, which, given everything that we had been doing, is actually quite concerning and reminds us how highly contagious SARS-CoV-2 really is. We also learned that we averted 12,000 deaths, roughly, by having these public health measures in place. So you heard Congressman Levin talk about, what our numbers look like here in San Diego County. That is wildly reduced because we have been able to engage in these behaviors and show love and support for our community. So I just want to, put that basic spin on the conversation that we're going to have here later on today, because we in the public health community, we're thinking about prevention of that infection, even though we realize sometimes it's hard for communities to really understand that because we're generally used to reacting to an infection being present. And so really thinking about preventing it and the things that we can't see versus waiting for something to erupt and having to respond and use community resources to address them. So those are my comments to set the stage for what it is that we're going to talk about today, and I look forward to hearing your questions.
Well, Dr. Anderson, thank you for that outstanding opening statement. Truly grateful for all the work that you have done and continue to do to keep people safe and healthy, and to make sure that we've got the testing and the tracing necessary to do all we can to just reduce those numbers. And very, very grateful. And I hope you are hearing that a lot from a lot of people.
Yes. The answer is yes. And I have to say, there is no I in team. Oh, this is a massive effort. And I'm really fortunate that I work with brilliant scientists and people who are generally very compassionate, because, we do this really on an unfunded mandate, and because we care so much for the community that we serve. And so our teams have really done a great job coming together. We've been, lifting each other up, and in those days where, the daytime work turns into the nighttime and the weekend work, staying really positive and feeling good that we can meaningfully contribute.
Well, we appreciate you very much. I had some very basic testing questions that have been on my mind. We've got a bunch of questions from our viewers, but I'm just going to throw out a few questions of my own. Why is it important that we increase testing as much as possible?
Yeah. So you heard me say earlier that in a public health crisis, you need public health measures. And there are 4 things that we've learned over, our history that tell us we need to be doing if we want to get to the other side of this pandemic and get there in an effective way. So one is, for any infectious condition, we need to be able to identify as early as possible where those infections are occurring. And so this is a routine part of county health departments and state health department activities. We've just never had to mount the magnitude of the response that we're having to mount right now. But having adequate testing, and particularly having testing available in neighborhoods that are disproportionately affected by whatever condition it is that's being dealt with. So in our case, we need to test for early detection. We need to test for early response. So when that test provides us with a positive result, there's an action that many people are now familiar with, of self-isolation that becomes really important. And getting individuals removed from the community setting as soon as possible. Again, to interrupt transmission is really important. We also think about early detection because quite often the impact of the infection is different across different individuals. If you have various underlying health conditions, you could experience this very differently. And we've seen that play out across the demographics in our communities. And so identifying it early so that we can react effectively is really important. So we need to be doing that widespread testing. The other thing that it allows us to do is to identify individuals who have been in contact with the cases. And so we investigate cases to understand and elicit their contacts. We investigate contacts to understand, are they also at high risk for severe symptoms, and are they at high risk for transmitting the infection, and then quarantine those individuals. So these four pillars, they come together as a package, but the initial testing piece of this pillar drives what happens afterwards. So that's why it's so important to have adequate testing, and I can't stress enough, testing in those communities that get disproportionately affected by various infections.
Terrific. The next question, I have two more for you. Clearly, at the beginning of this, there was a problem with testing capacity. We didn't have the kits, we didn't have the swabs, we didn't have the reagents, all kinds of problems. Now it looks like we're beginning to solve some of those problems, and there is in some parts of the country, and certainly I think here locally, we got a pretty good handle on capacity. Now there seems to be a disconnect between capacity and demand. So to the extent that we're not testing the 5,000 plus a day, I've heard, the tests are available, people just don't need them. They're not being requested. So my question for you is, how does the criteria for who gets the test change as the capacity for the tests increase?
That's a great question. So, a key public health principle would apply here, which is meet people where they are. Like, we are in various approaches to public health challenges. Any good approach will fall down if you always depend on people to come to you for whatever is needed. And in this case, people needing to find a public health testing site or figure out where it is that they can and how they can get their tests. So we really need to mount a strategy, if we're going to be effective, that allows us to meet people where they are. So what do I really mean about that when I say that? So the idea here is that in San Diego County, for example, there is a fantastic accounting of the epidemiology of SARS-CoV-2 that happens every single day. And it's being tracked and available to our residents via our San Diego County website. And we are able to see as citizens, where things are disproportionate. And so in order to do this well, we need to go to, the zip codes where we see those death rates that are wildly unacceptable. And we need to take the tests that we're offering to those areas, and we need to figure out, even once we're in the areas, what are the barriers for the citizens of those areas to get their tests. So, we know that even if, you set up a tent, it doesn't necessarily mean that, someone's gonna come to it. So really keeping in good touch with the residents of the area is going to be very, very important.
How about higher risk groups? We've seen a proliferation of cases in deaths in nursing homes, in prisons, in food processing facilities. Would it make sense, if there is in fact a capacity that exists, to use those tests proactively in those high-risk communities?
Yes, so you're raising an important point about, not only people who are at high risk for very severe complications from SARS-CoV-2 infection, but also who are in settings that put them at high risk for transmitting SARS-CoV-2 to others. And so especially in those circumstances, the prioritization that should happen for resources needs to be quite clear. And when we as a community find that any one segment of our community has been more abundantly, blessed with tests or with other resources, to whom much is given, much will be expected. And so sharing those resources across the community, again, taps into one of our basic public health strategies so that we can reach those individuals who otherwise wouldn't be reached.
But the whole idea, so I couldn't agree with you more. The whole idea of meet people where they are is so important, meaning that counties have to be proactive, that it's not enough to just wait for doctors to send patients.
That's right.
And then to say, well, the doctors aren't sending the patients, so we've got the tests lined up on the shelf. So clearly there's not a demand.
That's exactly right.
All
exactly right. Removing all barriers. When you hear something along the lines of, no one's asking for it, or, we don't have any infection here. Well, how many people are you effectively reaching out to?
Yeah.
And if it's different if you've, reached out to them and they've said no thank you, than if you haven't reached out to them and you've concluded that they don't need it.
Excellent. All right. That's really helpful. Lots of questions. I'm going to start with Deborah in Carlsbad. Deborah asks, my husband and I are 65 years old and care for my 93-year-old mother who lives in an apartment attached to our home. Prior to the pandemic, we had part-time caregivers to help with mom's care. Our caregiver, who also worked at a facility, left our employ on March 7th. Under what conditions and when is it safe to bring a new caregiver into her home? We need assistance with caring for mom and her home dog. Her vision and mobility are limited, but her mind is sharp, and companionship is also an important part of this care. Any thoughts on that?
Yeah, Deborah, what a great question. And sounds like you have a beautiful relationship with your mom. We would want to think about a couple of things in a scenario like this. And so one is healthcare personnel. How are they going to be monitored and effectively screened before they might be brought into what in your case would be a new work environment? And the San Diego County Health Department, and I'm sure Orange County probably would have this as well for those listening who are in that part of the area, will have guidelines on what should happen when a sort of return to work or a new work situation gets set up. This will include some symptom checking. Sometimes it'll mandate that temperatures be checked to see if fevers are being exhibited. In the event that, thermometers, which have become a really difficult thing to get one's hands on, aren't available, then there are other panels of screening that should be taking place. Also, really educating your mom and monitoring her should she begin a new care situation for any possible symptoms, and thinking of a plan if she were to get infected. So here, you want to prepare for the worst case scenario, but you want to, work toward the best case scenario. So having those screening provisions in place, yet also having a plan for possible infection is going to be important. Another thing that we've heard a lot of statewide and nationwide talk about is personal protective equipment. So ensuring that there's very good and clear access to PPE, and that any infection and prevention control practices that we have put forward around SARS-CoV-2 are being adhered to.
Thank you for that, Doctor. Steve in Oceanside asks, my daughter works as a dental assistant at a practice in Oceanside. The doctor is gearing up to open his practice next week. I have been on multiple websites reviewing guidelines, and dentistry is a very high-risk profession. How can a dentist know, even with a negative test, tests are not required unless screening indicates a problem, that a patient is not infectious? If a very high degree of certainty for negative test results are not being achieved, which seems to be the case, should dentists choose to treat anyone where aerosols may be generated?
Yeah. So, here, this is really going to depend on the type of procedure that procedures that the dental practice wants to engage in. You may have been hearing quite a bit of new information lately in the community setting about many different types of healthcare settings, rethinking about how they approach providing essential care at this time, while they're also effectively able to provide care for individuals with COVID-19. And so balancing the benefit to the patients with the risk to the clinicians is going to be something that's really important. We were at a time in our country where protective equipment was in short supply. And so ensuring that anyone who's working in this setting has adequate personal protective equipment, which in many healthcare settings we see it works well in terms of interrupting transmission. This will include N95 masks, ensuring that gowns and gloves are there. There also needs to be some discussion around proper donning and doffing of personal protective equipment so that infection transmission is minimized, and maybe also rotating staff. And one of the strategies that's been taken in several healthcare settings is to do those things that I talked about earlier, testing healthcare workers, ensuring that it's done on a frequency that makes the organization comfortable that they're able to pick up new infections if they were to be occurring amongst their workers. So really thinking about it both from the patient perspective as well as from the provider perspective is important here.
Thank you for that, Doctor. I know a lot of our local dentists are thinking about reopening now. Some other ones are thinking maybe next month. And I know also the procurement of all the PPE is still difficult for those with private dental practices. And I learned new words today: donning and doffing. These are
putting on and putting off, taking
exactly.
off.
No, I got it. Ryan asks, it is my understanding that private sector medical researchers have been on the front line in helping us innovate new technologies for combating and addressing this issue. How is Congress working with the private sector medical researchers to expedite the development of detection, vaccination, and treatment technologies? Well, Ryan, that's exactly what we've been trying to do now, going on 3 months with every part of legislation, every piece of legislation that I mentioned at the introduction of this town hall. We have included provisions to help our biotech and life sciences companies with research, development, and deployment of diagnostics, therapeutics, and of course the vaccine. And that means we've included tens of billions of dollars in every one of those bills, at least billions of dollars in every one of those bills for everything from NIH to BARDA to related agencies. And I'm really quite encouraged by a lot of the companies locally and what they're working on. Really, I think some of the thought leadership in the entire world is happening in our area and in our district specifically. And I'm very grateful to all of our companies that are doing a wonderful job, and all of our research institutions as well. And that certainly includes UCSD. Manny in Encinitas asks, and this is for you, Doctor. My wife and I are in our 80s. Do you recommend that I clean grocery items brought by my volunteer driver? They are all packaged individually.
Wow, Manny, what a question and dilemma, right? So, for this question, I think going back to some of the basic principles of infection control are important here. So with SARS-CoV-2 infection, we know at this point that some clear strategies can help. Washing one's hands, keeping one's hands out of portals of entry is what we would call them in a more technical term. So your eyes, your nose, and your mouth. And sanitizing your hands if you aren't able to wash them. And again, ensuring that you protect your portals of entry. So that would be the most efficient way to minimize risk of transmission here. Now, our own personal tolerances is something that we should probably consider here also, and our own personal behaviors. And so if you worry that there's a surface in your grocery delivery bag that may be a surface that the SARS-CoV-2 infection could live on for an extended period of time, and it would worry you if that surface wasn't, cleaned, or you were going to have to touch your groceries, within a very short time after someone who might possibly be shedding virus had touched it, then you may go to greater extents than what I just described. But, efficiency in reduction of transmission here is going to come, a great deal of it, from keeping hands clean, and protecting, again, those sites at which you could introduce the infection into your body.
Thank you, Doctor. Sandra in Oceanside asks, the EPA has a list of disinfectants to be used against COVID-19. The EPA table has on it contact time, that's in quotes. Is contact time the amount of time a disinfectant product needs to stay on a surface in order to kill a virus? If that is the case, how do you assure these products are being used correctly at places like gyms? Great question.
All right. So to answer the first question, yes, that is what contact time means. And, this is going to be difficult because, unless you are there looking at them all the time, it's going to be hard to know what exactly people are doing in these settings. But I think just like when we go out to eat and we engage with other parts of our day-to-day society, there are standards that everyone's being held to for sanitation, and we rely on the goodwill and education and proper practices of individuals who work in those settings to wash and sanitize as they should. Now, if you are in a facility and you're not comfortable with what might be going on in the facility, I think you could ask. You could say, what's the contact time of the cleanser that's being used here? And the answer could be very telling.
If they know.
Yeah.
Elizabeth in Dana Point asks, my daughter works in the kitchen of a restaurant in Dana Point. They want to reopen, but she is hesitant to return to work because I have autoimmune disease and she doesn't want to endanger my health. They have told her that they will be taking temperatures of all employees and providing masks, but I want to know what kind of protocols will be required to protect workers. Well, from a policy perspective, obviously, I first and foremost can understand your concern and also your daughter's desire to protect your health and her own. I think the governor has evolved a bit in terms of restaurants lately, and depending on which county, and in this case, Orange County, what phase the county is in, there may be an opportunity to begin reopening restaurants with a limited percentage of tables open, things like that. I know San Diego County is now exploring 25% opening capacity for restaurants. But I think to the extent that your daughter works at a restaurant, critical that she be provided with a mask, gloves, that the restaurant's doing everything they can, not just taking temperature, but doing everything they can to prevent the spread of the infection. And Governor Newsom also says that Cal OSHA standards have to be adhered to, as well as CDC and CDPH standards. So my hope is that that will be the case in her restaurant, and that she can go back and work safely and not create any health impact for you. I think that would be critical. Anything to add, Doctor? Any of that?
That's very well said.
Thank you. Jennifer in Oceanside has a question for the doctor. My spouse and I are in the vulnerable group and practicing all COVID rules. As San Diego County is starting to open up and still saying that the rule to wear face coverings is indefinite, we see lots of people out with no mask. That scares us more and more, that people will not wear masks in the future and we will be in danger for as long as the virus is here. Should we say something to those not following the rules?
Oh, Jennifer. Okay, so so I think one is we should remember that our public health officer, Dr. Wilma Wooten, her general slogan around this is, if you leave your place, you should cover your face. However, when you look at what usually follows after her slogan, there are some exceptions for which not having a facial covering is okay. If you're out for exercise, explicit, exercise, running, I think is one of the ones that gets called out. If you're out in a family context, the people who live in your home together and you're out for recreation together, and you as a unit are socially distanced by 6 feet from other individuals or families. And so I would, one, just familiarize myself with the exceptions to face coverings before drawing any major conclusions, and the consequence actually for not following the health orders are in place. It can be fines and imprisonment. And so our local authorities are aware of this, and I think that they are going to be doing what they can to try and ensure enforcement. But I want to just, come back to something that we talked a little bit about earlier, which is about, public health taking the focus off of the individual person and really thinking about how, in love for our fellow man and woman, we can protect each other. And so to the extent possible, if people aren't engaging in those, exempted activities, then we should have our faces covered. And the extent to which you confront someone around that, it would have to be up to individual preference. But I sure do hope that what will be contagious, while we're dealing with the pandemic, is this love and care for another through some simple actions.
We need all the love and compassion we can get these days. Jennifer, oh, no, we did Jennifer. Okay. Mark asks, with America heading quickly toward depression and widespread poverty, what is your plan to put Americans back to work? Mark, that is an excellent question. That is something that I think about every morning when I wake up. I see the numbers, both in terms of the public health crisis that we face and the numbers in terms of those seeking unemployment. And it's just astonishing. And you're right that we are quickly heading towards a extended recession if we're not careful. It's going to resemble depression. We're talking about in San Diego, the numbers are unemployment that Sandag has projected at around 28%. And I worry tremendously about the long-term implications economically of all this. So a few things. Number one, I have said and will continue to maintain that we can't solve the economic crisis that we face unless we solve the public health crisis that we face. So absent a true series of measures to restore public confidence and to beat the worst of COVID-19, it's going to be very hard to envision a scenario that we're going to have a strong economic recovery. That means we need to do all the things that Dr. Anderson's talking about. We have to dramatically expand testing and contact tracing. We have to make sure that there are available treatments and that we isolate those who need those treatments, and that ultimately we do develop and distribute that vaccine as quickly as we can. You cannot have a healthy economy without healthy people. So our first and most important objective has to be getting the public health crisis under control. That being said, we also, now with 37 million Americans out of work seeking unemployment insurance in the last 8 weeks, we have to do a whole lot more than just provide a stopgap during the pandemic. We're going to have to put millions of Americans back to work. And I strongly believe and will continue to advocate for a bold plan to create millions of jobs with the infrastructure that we've needed already. Things like broadband. We have over 21 million Americans that don't have access to quality broadband. How are we supposed to work from home, study from home, see our loved ones from home virtually if we don't have access to broadband? We can't. Just the same, we have major problems with our water infrastructure, with our electric grid, and we have significant upgrades needed to our transportation infrastructure. We needed to do all these things before the pandemic. And that's why in January, end of January, we introduced in the House the Moving Forward Framework for a $760 billion infrastructure package that the need for that has only grown since all this, and it would put millions and millions of Americans back to work. In addition, we have to do everything to continue to support our small businesses as we look to expand and improve upon the Paycheck Protection Program. So a lot of that was in the HEROES Act. The infrastructure piece is something we still need to work on, and it's something that has bipartisan support. Both the president and the speaker, they don't agree on a whole lot, but they agree on the need for infrastructure. So I'm hopeful that we'll be able to work with the Senate, and we'll be able to get that over the finish line this year, again, to put millions of Americans back to work. That's just a little bit of what I could talk about. There are a lot more examples, but I'll leave it at that for now. Naomi in San Juan Capistrano asks, the latest data on COVID-19 and its spread indicates to me that even California is not doing enough to contain the problem. This includes the continued construction of large structures in LA County, not protecting Latino essential workers. As doctors, what are your ideas of how politicians can effectively communicate the data showing the probability that one can get COVID more than once, that we are potentially looking for 2 years or more of this, and that there is currently no foolproof way to determine a person's immunity so that we don't worsen the situation? Tough question.
That is a tough question, but we're going to try and take it on. Okay, so several pieces here. So one is, emergency preparedness and communication. And we have several things that we can go back to for inspiration in times like this, right? We think about communicating hurricane warnings, earthquake warnings, various other wildfires, in particular in this area. And what we know is there has to be an extremely high level of coordination, and there needs to be an extremely high level of coordination and even some redundancy in any communication system. So your question is about how do politicians communicate effectively so that people can get on the same page about what it is that we know. Now, remember, this is a 6-month-old disease, 2019 novel coronavirus. And in the initial stages of this disease, things were changing by the hour. And some of the things that are embedded in your question, we may have some data from places that are experiencing the epidemic ahead of us or the pandemic ahead of us, but we don't necessarily have the robustness in the evidence and the scientific rigor in evaluating some of those questions yet to come to any definitive answers. And so I think a part of how politicians may communicate is, one, being clear about what we are learning, and also being clear about what we don't yet know definitively. I think there's some real interesting opportunities present in the questions that you asked. Number one is for us to get a handle on the different strains of SARS-CoV-2. And that's going to require some really strong molecular epidemiology work. There are scientists around the country right now, including us here, in San Diego, who are embarking upon understanding that better. That'll give us a sense of if we see reinfection in individuals, what the original infection looked like, what was its molecular characteristics, and what are the molecular characteristics of that repeat infection. So your question is great. It's complex, but I will say, a highly coordinated response across politicians, highly sort of communicated, and also some redundancy and explicitness around what we don't know.
Thank you. Next question, again for you, Doctor, is from Dennis in Solana Beach. Dennis asks, the USS Roosevelt crew appears to have had crew members test positive, then later test negative, a week later again test negative, and following all of that, retest aboard ship positive. Is this only a factor of testing accuracy, or does this imply that having the virus provides no immunity?
Yeah, so I like the way Dennis put that question, because there are other factors besides the characteristics of the test that impact whether or not you see a positive or a negative result. And one of the things that I think we forget sometimes in SARS-CoV-2 is that it becomes apparent initially in the lungs. And so you could just imagine if we tried to do lung screening on every single person who we thought a testing was indicated for, we just wouldn't have the kind of resources to do that, right? And so different types of tests have been developed. One for feasibility purposes, for accuracy and validity in determining whether or not someone is infected or who isn't. And those things must be brought into view when we're trying to answer a question like yours. So your question is, if you get a test result today, whatever you see on that test result is really about the state of the infection today. And because of the biology of SARS-CoV-2, you could have infection happening in the lung and not yet the presence of viral shedding in the areas that are being tested by whatever method is being used. So in some cases, there's a nasopharyngeal swabbing that happens. And in other cases, there's a mid-turbinate swabbing of the nose that happens. And then in some cases, you have a blood test, a nucleic acid test. And so depending on, what those tests are indicated to measure, you would have a different ability to determine where and how that viral shedding is happening. So I wouldn't draw too many, conclusions about the fact that, people are being reinfected. We would really need to understand more details about at what point in the infection the tests might have been taken.
Thank you, Dr. Anderson. Here's a question from Rachel. Rachel has a different viewpoint, but we want to make sure that we reflect other viewpoints. Rachel asked, why is this COVID even considered a pandemic? Why do we not have precautionary measures with the flu that kills way more people every year?
Yeah, so it is an important question to get answered. The pandemic definition is actually something that gets applied through our World Health Organization and the standards that they use to understand when an infection or the presence of some condition exceeds what we would expect to be happening ordinarily. And so you may recall that initially we were experiencing epidemic numbers of SARS-CoV-2 infection, and later it was declared to be a global pandemic. And so the reason why we have to be so vigilant at this time is there are clearly things that need to be in place where we need to understand the amount of infection that we're dealing with. We need to understand the transmission and the transmittability of that infection amongst our population, our community transmission, and how it might be playing out in special populations. And then we need to be mindful of the fact that with the flu, we have a vaccine, we have therapy like Tamiflu that individuals can take, and we don't have that for 2019 novel coronavirus. And so vigilance is warranted here as we're dealing with a highly infectious condition, and we have no treatment, no vaccine, and we're mounting a public health response that's going to help us to do early detection and hopefully minimization of any effects from the infection.
No treatment, no vaccine, just minor difference. Anyway, Teresa asks, what advice do you have for those that have a diagnosed hearing loss in reference to avoiding ototoxic medications and ADA 2010 compliance with COVID-19, as communicator masks are not largely worn by those serving the 20% with hearing loss?
Yeah, well, first let me throw in there, Teresa, that as Congressman Levin's reading your question, it occurs to me that we should have, and I think Congressman Levin's group is working on having interpreters and sign language here on these town halls for individuals who may have hearing loss. And so we'll, make sure. Yeah, we'll make sure we do that. This is really admittedly out of my scope, but it seems prudent from the question that you asked that for sure, if hearing loss is an issue, do stay away from meds that would cause some additional, aggravation of your condition.
Next question for you from Aaron in Carlsbad. Aaron asks, my question is on masks. There seem to be few, if any, clinical studies on the use of masks, and we seem to be driving a social wedge in our society over the mandate. There seems to be little to no evidence that it contains contagion. I'm not a doctor, but I was a chemical warfare officer, and PPE is only as good as the user. I do not know that not changing or decontaminating even the best masks only make them worse. Why are we doing this to ourselves?
Yeah, so Aaron, I think you're raising the point that not all masks are created equal. And as widespread public use of masks came into being recommended, a couple of things were under consideration. One is that what we've now all become familiar with, N95s and their various different types, have been in shorter supply than they typically are. And so, people were encouraged to cover their faces with other types of facial coverings. Now, what happens is similarly to when you cough or sneeze and you do it in your elbow, as you've probably, we teach our young ones, it is preventing droplets from reaching other people. And so the face mask is more of a constant direct control of droplets. And so it is, going to likely just minimize what one person would be able to do in terms of transmitting over to another.
Thank you for that. We got a couple questions about Orange County and enforcement of safety regulations. What I said at the outset and what I'll repeat now is that I'll be meeting in the morning with public health officials from Orange County to understand what's happening on testing and contact tracing, to see that we can do everything possible to be supportive and work collaboratively to try to adhere to the state's guidelines around reopening. I think everybody wants the same thing, which is to reopen safely and to do so as quickly as we can. So hopefully we can all work collaboratively, listen to public health experts like Dr. Anderson and other medical professionals when we're making decisions about how quickly and what businesses we reopen and when. But thank you to Sam and San Juan Capistrano and others for those questions. Gail has a question for Dr. Anderson, and it's a simple question. What is the best disinfectant to use on countertops and bathrooms for coronavirus? And does Lysol do anything for viruses? So the label says it does.
Yeah, so there's an EPA, our Environmental Protection Agency, has a list of disinfectants that should be adhering to rules for saying that they're able to deal with viruses. Lysol, many of their products are on the EPA list that would give us confidence that they should be able to address the scenarios that you are thinking about in terms of protecting your countertops and your bathrooms from coronavirus.
Just don't ingest it, don't inject it, none of that.
None of that.
That's already a couple weeks old. We've already moved past.
Yeah, hopefully everybody's clear on that now.
Surprised, Doctor. You'd be surprised. Rod in Oceanside, another one for you, Doctor. He asks, I own a small business and I'm considering taking temperature readings from all of my staff and patrons when they enter the building. However, in many cases, we have heard that people infected with the coronavirus can be asymptomatic. Is there a breakdown of how many or what percentage of people are asymptomatic? Is it 10%, 20%, or more? This information can help in deciding on when I should open my business.
Yeah. So, Rod, I appreciate your question and your commitment to surveillance within your community and workers. The best data that we've seen so far suggests that 30% of individuals who have SARS-CoV-2 infection actually had a fever associated with it. And so we're balancing, thinking about some basic infection control methods with screening methods that could help influence your decision. And so I think one of the things that I'd put on the table for your consideration is if, you would like to use temperature checks and fevers as a way of that determination, then okay, but you're going to need additional corroborating information. And you also will need to put in place some very simple hygienic practices and some public health practices where, people are being distanced from each other appropriately, et cetera, to, again, avoid that potential transmission of the infection. So good hand washing, good hand sanitation, remembering to protect those portals of entry, your eyes, your nose, your mouth, so that you can keep your set of workers safe.
The other term for the week is portals of entry. So donning, doffing, and portals. I love it. This is great.
My students, if any of them are listening right now, they're going, I learned that model of infection. I know how that goes.
Here's a question from Jenny in Oceanside. She says, so many are downplaying the danger or spread of COVID-19, including some health professionals. Who do we believe? Well, I, for one, believe you, Dr. Anderson, but who do you believe?
Yeah, that's a great question. So, all of science is, it's about judgment and rigor and ensuring that we have standards by which we use to judge whatever we're being presented with. And so we, in a medical and public health community, we look to our peer-reviewed journal publications being done by our science peers across the world as one of our most important sources of information. And so as SARS-CoV-2 was new and things weren't necessarily published yet for us, we were keeping in contact with colleagues across the globe, trying to understand what was going on. In my case, I have a really close colleague here in San Diego who worked in Italy for 12 years. And, we'd have a huddle every morning so we could understand what was happening in Lombardy region, in Veneto region, how the differences in their medical care approach, when they were using PPE or not, how the differences in their public health approach, when they mounted large contact tracing efforts or not, when they really doubled down on testing. And so before it could make its way to the journals, we were reaching out to our trusted colleagues across the world to get that information. So I would say, to the extent that you can get your hands on peer-reviewed scientific literature and you get excited about that stuff like I do, that's a really great source of information. Our universities, I can vouch for the UC San Diego team. We have a fantastic group of scholars. My department is family medicine and public health. Our colleagues there are just amazing, civic-minded. They really don't mind when people reach out to them. We also have an amazing infectious disease team. We have a global public health team that is also really quite on top of this.
Well, we are incredibly fortunate to have you as part of our community helping lead the way as it pertains to our strategy around all of this. And I just can't thank you enough for all the work that you are doing and so many of your colleagues at UC San Diego as well, really leading the way. And I can't say enough good things about all the wonderful people at UCSD. So thank you for everything that you're doing. With that, we are about out of time. But I wanted to leave Dr. Anderson some time to make any closing remarks about really anything that you've got coming up that you want to inform the community about. We do these very frequently, really to try to provide that information. It gets to that last question, who do you believe? I hope that every week we provide some good basic public health guidance and advice around this in policy updates as well. So with that, Dr. Anderson, any concluding thoughts?
Yeah, first I'd like to say thank you for having me with you today. The fact that, public trust has been given to me, I don't take that lightly. And I appreciate the, opportunity to really represent scores of people who, contribute to my continuing education on what's happening with SARS-CoV-2 and COVID-19. And so I just want to remind us all that this is a really difficult time. I take this from a very, public health oriented perspective, but I understand that, there are economics involved here. And in public health, we're thinking, not just about, one's physical health, but we're also thinking about your mental and spiritual well-being. And so we're going to be stronger together always. And I just hope that, we spend as much time thinking and discussing our physical health situation as we will thinking about our mental and our spiritual health situation as we try to get to the other side of this.
Well, Doctor, you are fantastic, and I hope you'll join us again in the weeks and months ahead. We intend to keep doing these until we can do our actual in-person town halls again, which I miss a great deal. And it's sort of the new normal of trying to figure out how we represent people. But thank goodness for Zoom, and thank goodness for Jeremy, our great videographer, producing all of this and making it look nice for Twitter and Facebook and YouTube. I hope this was informative. I hope that you learned something that will serve you in the days and weeks ahead. We're going to keep doing these, as I mentioned. I hope that everybody can tune in this next Wednesday, so a week from today, at 7 p.m. on Fox 5 in San Diego. A number of affiliates up and down the state of California will all be doing a town hall with a number of my congressional colleagues. Really looking forward to that opportunity to continue the dialogue. Until then, I hope everybody continues to follow the guidelines as set by the CDC. Incidentally, the CDC this morning came out with about 60 pages of specific guidance for different types of businesses, whether it be childcare, restaurants, et cetera, et cetera. So I hope if you're in those industries that you check out that guidance from cdc.gov. Just the same, I hope we all follow the guidance from the state of California and CDPH, as well as San Diego County and Orange County. I look forward to hopefully being able to see many of you in person in the not too distant future. We're all looking forward to the day when things can get back to some semblance of normal again. But until then, I look forward to seeing you virtually, and I hope everybody stays healthy and stays safe. And again, if you need anything at all pertaining to any of the federal legislation or programs that we mentioned, please don't hesitate to contact our office. Probably the easiest way to do so is by phone, and you can see all the relevant contact information on our social media, or if you go to mikelevin.house.gov. So until then, thank you to my team, and I hope everyone has a great week. Take care.